In previous video, we discussed about GCSF, birth in endometrium, especially in IVF. Continuing with our series of improving the endometrium, in this video, we will discuss about another modality to increase the endometrium. That is a bit controversial modality, but I use very frequently. That is called as endometrial scratching. Many times it so happens during the time of frozen embryo transfer or during the time of cell cycle, the endometrium does not improve more than 6 mm. In spite of giving routine conventional low dose aspirin, vitamin E, L-arginine, sildenafil citrate, pentoxifylline, even estradiol valerate for that matter, the endometrium does not increase. Sometimes because of the endometrium, the implantation failure occurs. Even if a good day 5, day 6 blastocyst, good embryo is there, even if a genetically chromosomally normal embryo is there, then also implantation then does not occur. Implantation failure occurs because of endometrial and embryonic asynchrony. Endometrial receptivity may not be good. Recurrent implantation failure occurs. In those cases, we think of doing something called as an endometrial scratching. Today's video we will discuss what is endometrial scratching, how endometrial scratching is done, how much does this cost, how long does it take, is it a major procedure, any side effects, what are the possible mechanisms of endometrial scratching for improving the endometrium, and what the recent Cochrane data says about endometrial scratching. Good morning, you have started watching our YouTube channel, The Fertility Gynecologist, and I am your host and host, Dr. Rajat. I am a gynecologist. So what is actually an endometrial scratching? Endometrium, as the name suggests, it is the scratching or a deliberate surgical injury or a scratch put on the endometrium before the cycle, before the transfer, which is put with an intention to heal, to promote the growth of cytokines and various growth factors as so that the embryo implants well in the next cycle. Now, in guinea pigs, the history says that scientists were aware that in guinea pigs, when the endometrial biopsy or DNC was done, it led to an improvement in implantation rate. But in human beings, the history of endometrial scratching is about 20-25 years old. Somewhere around 2000s, the reproductive endocrinologist found that the patients in whom dilatation and curettage or HSG the cycle before or hysteroscopy the cycle before, in those patients, the results of embryo transfer were found to be better compared to the patients who did not undergo DNC, endometrial biopsy, HSG or hysteroscopy the cycle before. So that led to the research of this topic called as an endometrial scratching. First of all, I have discussed what is endometrial scratching. It is basically done by this small 1 to 2 millimeter curette called as a pipple curette. You can also use a simple MTP cannula, simple very thin 5-number cannula. This is a 7-number cannula, but you can use a 5-number cannula also. This curette, roughly about the previous cycle, 7 to 10 days before the intended frozen embryo transfer cycle. What I do is 7 to 10 days before the cycle, this small curette is put into the uterus. This is a negative suction cannula. If you pull this thing can be pulled. It creates a negative suction inside. We put it inside to the top and then slightly withdraw, and then with rotating movement 2 or 3 times we take it out. So our main purpose is to injure the endometrium superficially, is to scratch the endometrium superficially, because it is a negative suction pipple curette. It will take the negative suction and along with it, it will take the endometrium out also, and it will scratch the endometrium. It is hardly a 2-minute procedure. It can be done as a daycare procedure. Anesthesia is not usually required for this procedure. Normally, what I do is the cycle before the transfer. Suppose the patient has to undergo the cycle transfer. Next cycle, I put the patient on oral contraceptive pills. About 11th, 12th or 13th day of oral contraceptive pills, I call the patient. I give patient tablet misoprostol about an hour before so that the cervix becomes soft and the dilatation becomes relatively easy. And then I just do it like a DNC. It goes inside, rotate it and take it out. And the patient continues on the oral contraceptive pills. Patient completes the oral contraceptive pills and then she gets the withdrawal, and next cycle the process of frozen embryo transfer starts. How does this endometrial biopsy or endometrial scratching or they help in the implantation next cycle? The studies have suggested that injuring the endometrium would lead to the release of various cytokines, various growth factors, and deliberate endometrial injury, it leads to the increase in various factors which are helpful in implantation like laminin, glycodelin, and they definitely help in the implantation next cycle. But there are a few arguments against endometrial stretching also. Some people say if you are doing the endometrial stretching in the previous cycle, if the growth factors have to be released, if the cytokines have to be released, they will be released in that cycle, how it will help in the next cycle. This endometrial, the other argument is, yes, it improves the immune system, it improves the growth factors, but not all females, not all uterus of females who are undergoing an IVF treatment or an infertility treatment will have an underactive immune system. Most of them will have an overactive immune system also. Most of them will have a normal immune system also. While it is not denying the fact that endometrial stretching would definitely help an underactive immune system, it will stimulate the immune system into overdrive, it will help in the production of more growth factors and thereby increasing the growth of endometrium in the next cycle. So, in spite of knowing this since last 20-25 years, we doctors and scientists have still not been able to find out in which patients endometrial stretching should be done. Should it be done routinely, or in which specific particular type of patients the endometrial stretching helps. When I was young, about 10, 12, 15 years back, I used to do endometrial stretching in all the patients of IVF cycle before transfer. But over a period of time, I have realized that endometrial stretching does not help in all the cases. Endometrial stretching, it helps mainly in cases of recurrent IVF failure, in whom there have been 2-3 times embryo transfer has been done with good quality embryo, and either thin endometrium, or in spite of that, in the endometrium being good, the success is not happening. So recurrent implantation failure, endometrial stretching is one of the factors to do to improve the results of a recurrent implantation failure. It may not help in all the cases of IVF. It should not be done in all the cases of IVF. Currently, I am doing a study in which various immunological factors, various cytokines, various interleukins, if they can be known in the previous cycle of IVF, we can know, and that can categorize whether the endometrium is underactive, whether the endometrium is normal, or whether the endometrium is overactive. If endometrium is underactive, then in those cases we definitely need to go for endometrial stretching the cycle before. If endometrium is normal, or if endometrium is overactive, there is no role of endometrial stretching as such. On the contrary, if endometrium is overactive, we need to suppress the immunity by giving steroids or something like that. But again, all these things are controversial. Nothing has been proved. We need good long-term randomized controlled trial studies. But in those patients in whom there is a persistently thin endometrium with no past history of multiple dilatation keratosis, no past history of tuberculosis, and all other factors have been ruled out, there is a good uterine, good spiral artery blood flow. In spite of that, if the endometrium is not increasing, then endometrial stretching is worth trying. Some people do pre-IVF hysteroscopy, that means hysteroscopy the cycle before transfer. Hysteroscopy is putting a hysteroscope inside the uterus, putting a camera inside the uterus. And with hysteroscope, not only can we see the endometrium, not only can we see the glands of the endometrium, the ostia, the cavity size, the health of endometrium, but hysteroscopy also helps in making a deliberate surgical injury. With hysteroscope at posterior part of the fundus, just about 2.5 centimeter below the fundus, where we intend to deposit the embryo at the time of embryo transfer, we create a slight injury with the hysteroscope. And that is also one of the logics of getting a better result with embryo transfer next time. Same logic of endometrial stretching and endometrial injury applies in HSG also. Many gynecologists must have found that when they do a hysterosalpingography, either in that cycle or in subsequent next cycle, the chances of pregnancy increases. Hysterosalpingography not only clears the sludge which is there in the fallopian tubes of the uterus, it also disturbs the endometrium superficially, because if you see the hysterosalpingography cannula, HSG cannula, it basically reaches just to the middle of the uterus, and when we push the dye, it disturbs the endometrium, and the mechanism of action is somewhat similar to the hysterosalpingography. But this endometrial scratching cannot be done in the same cycle, because if the endometrium is damaged, then the implantation cannot occur in the same cycle, and that is why endometrial scratching in normal patients who are trying timed intercourse, or normal patients who are having doing IUI, in those patients we cannot do an endometrial stretching. But what I do is some kind of a modification of an endometrial scratching. I do something called as an hydrotubation. Now what I do is I take a IUI cannula, intrauterine cannula. The thickness is somewhere like this. Around the ovulation time, either a day before or around the ovulation time, I put the cannula inside and I inject about 10 to 20 ml of simple normal saline, and that saline, it passes through the fallopian tubes and it somehow refreshes or disturbs the endometrium. The passage of cannula, it just touches the endometrium and it has got a mild endometrial scratching effect, and it many times helps. While it does not help in 100% of cases, it does not even help in 50% of cases. But like I always say, I always mention, per cycle, chances of pregnancy, if female has got one egg, is about 4 to 7%. If female has got two eggs, chances of pregnancy is about 7 to 10%. If there are 3 follicles which are formed, then chances of pregnancy are about 10 to 14%. If we do add IUI to that, the chances become about 17%. So these are minor percentages which lead, possibly by doing hydrotubation or possibly by doing the scratching the cycle before, we may increase the chances of pregnancy this cycle. What I do is, whenever I do HSG, the next cycle I make it sure that either HSG is timed if my patient wants a IUI next cycle. Then either I do HSG this cycle, or if HSG is expensive, patient is not willing, I simply do hydrotubation. I take an LW cannula, put it inside the cervix, flush the saline out. It might have a effect of an endometrial scratching for next cycle, and it also clears the sludge out of the fallopian tube, so that might improve the chances of pregnancy in the next cycle. In conclusion, I would like to say, while the Cochrane does not endorse the use of endometrial scratching for increasing the endometrium or thereby for increasing the implantation rates, there is a scratch trial which is currently going on as we speak. The results would be out in a couple of years' time as to whether the endometrial scratching does benefit the patients of thin endometrium, whether endometrial scratching benefits for increase in implantation in the next cycle, in what patients the endometrial scratching should be done. I personally believe, if there is a persistently thin endometrium in spite of trying everything, if there is a recurrent IVF failure, and for patients in whom there is an underactive immune system, like I mentioned, I'll put the chart for those underactive immune system patients, if somehow we can get it done. Now, getting those immune interleukins and cytokines from the endometrium is a bit costly affair. So I'm studying and I'm researching for those methods by which we can know whether, either with some basic blood test or with some clinical features or a combination of various things, if we can make it out whether that this uterus is underactive, whether this uterus is normal or overactive, so that we can identify those patients in whom the endometrial scratching would benefit. Till then, the only patients who, in my opinion, would benefit from endometrial scratching would be the patients of recurrent IVF failure in whom there was a morphologically and a genetically normal embryo which was put. I request you to please like the video, to share the video, and to comment. Thank you. Bye-bye.